Oh, you're done with yours. Okay, thank you. We'll get it to that. All right.
It just seemed like
Before I left the room, I think I touched this up here.
it.
It didn't seem like it did anything.
Oops.
It says no controls available for this device.
Yeah, I just kind of just kept clicking. That one can be closed.
You see, it's just sharp.
Oh, okay, it's back.
It's gonna be back.
Like, I think you just kind of wiggle it enough and it comes
Yeah,
back,
but we were,
but,
maybe it's just a
and then there, and then I don't know how to get it.
5-minute warm-up process.
Yeah.
Are you okay with this card? Do you have these?
Oh, yeah, I can turn that in. How do you get it into the presentation mode? Menu, view, okay. Perfect, all right.
It's up there. Right.
Are we,
you are sharing the screen or.
I can, is names on it? All right, and we are ready to get started. Are you introducing Dr. Wilson, or do you want me to?
You're there.
I mean, I don't care. I can just start the recording and you can take it away.
It's already recording.
Oh, it's already recording. Perfect. Thank you.
Yeah.
Yeah. Yeah. She had a card.
I don't know.
Right. Okay, we'll go ahead and get started. I'm sure more people will trickle in. How are we all feeling?
Cold.
How are we doing? Other than cold, let's move around and warm up a little bit. Okay, well, we'll get started with our afternoon, with our third session. We'll have one more, so thanks for being here. Hang out with us, hang in there with us. We have a couple great sessions this afternoon. Some cookies will be delivered at some point. We'll definitely have coffee next year for sure. I don't know if coffee is coming with cookies, to be honest. I'll ask that. But anyway, our third session is with Shenell, Hinton, and Rachel. Help me with your last name. Boeche. Just to give us some updates and a little bit of Q&A. So I'll go ahead and just turn it over to you guys.
Okay, thank you, Megan. All right, everyone. Nice to see everyone out there, and I hope you survived a wonderful lunch. My name is Shenell Hinton, and I am the nurse manager for the 6 North Ortho Spine unit at the Spinal Cord Injury Rehabilitation and the Rehab Institute. So I'm so happy to be here and discuss with you some of the updates that we have. We have great nursing team, of course, and as the year has progressed, we have been developing a lot of expertise in our nursing staff. And so that's what we're going to talk about a little bit today. So with that being said, let's go right into it. And some of this is going to be really a refresher course for you because a lot of this information you are already experts at. what I want to share about this presentation is that we utilize this for our nursing staff. So we want to hear from you. We want to hear feedback on if there's anything, if you know, or if you knew then, what you know now. And if there's any additional things that we could help our staff to know you better, because you've experienced this journey and we're experiencing it with you as well. All right, so we're going to talk about spinal cord injury education with a focus on bladder management. And the reason that I chose this topic is because this year in 2024, we decided to focus on decreasing urinary tract infections on our inpatient spinal cord injury unit. So we actually have a performance improvement project that we have put together. We've looked at all the causative factors related to UTIs. And so far, year to date, we're doing really well. The information will be more in detail at the end of this year. And we're doing a comparison to what happened in 2023 with many factors that could cause UTIs. So we're going to talk about that. So just as a refresher, we're going to go through the anatomy of urinary system and the digestive system a little bit, how they work, the factors that affect the system. We're going to talk about the options for bladder management, including the intermittent catheterization program and problem solving. As you all went through the journey, I'm sure you were told many of the options. And what we have been working on this year is the options that we have found to have good evidence-based research. So we have many partners in care as related to products that we utilize on the inpatient as well as the outpatient side for making sure that we can help with this reduction of UTIs. So as you all know, spinal cord injury does affect the bladder. We teach our staff to teach our patients as they're going through the beginning of the journey that before the spinal cord injury occurs, of course, the patient, you felt full, and then you found a bathroom, and of course you were able to handle that normally. After the spinal cord injury occurs, each patient is very unique and different. There is really no one size fits all, but you may not feel the bladder or the bowel being full and may not be able to empty the bladder on command. So because of these changes, we have to focus during the inpatient stay after the spinal cord injury has occurred on managing the bladder in a different way. So we are really, to be honest, laser focused on bowel and bladder management in our nursing team. And the best way to manage the bladder is to drain it before it gets too full, as you know. We also look at utilizing scheduled times to control the emptying of the bladder to make sure that we decrease accidents and also segue into decreasing that UTI rate. You've probably seen this. How many of you know everything about the spinal cord? Raise your hand. All right. All right. Hey, Dr. Wilson, you did a great job. See, so we actually utilize this because what we have found with spinal cord injury nursing, when we hire our nurses, of course, not all of them are experts in spinal cord injury. So as we bring them on, what we have developed in the past 12 months is making sure that we are giving them this up front. We want them to understand spinal cord injury, each of the different levels of injury, and what parts of the spine innervates what part of the motor, sensory, or autonomic functions. So we are teaching this. Just this past week, I even gave it to some of our student nurses that came onto the unit, so they can start thinking about that moving forward. Because each level, as you know, affects different parts differently. So when we're looking at the level of injury and we're looking at T12 and above, the upper motor neuron system, your brain, of course, doesn't receive the message that the bowel or bladder is full. The muscles controlling those openings can be very tight or spastic. And when your bowel and bladder are full, then they can be stimulated to empty. So the goal with that is to retrain those muscles to work automatically on their own. When the level is below T12 or the lower motor neuron system, the spinal cord doesn't receive the messages versus the brain. So that's from the bowel and bladder. And so those muscle openings can stay relaxed or what we call flaccid. Leakage can then occur, and then that's when the bladder or the bowel gets full, and we call it overflow leakage, which is common to the bladder. So this is, of course, what the urological system looks like. You've probably seen this. You have your kidneys, you have your renal pelvis here, you have the ureters, the bladder, and the urethra. Once that bladder fills up, the muscles work to usually stimulate it to open up and empty. So, but of course, in spinal cord injury, there's a lot of other factors that are involved in that function, which we work on while you're in the rehab unit with our interdisciplinary team to help you figure out what is the best way for this to continue happening with your new norm. So the urinary tract, the kidneys clean the blood. They remove waste, they remove the extra water. Your ureter tubes that connect or connects your kidneys to the bladder. And then the bladder stores the urine like a holding tank. And you could think of it like a water balloon. So then the more it stretches, it gets full, and then it needs to be emptied. And the urethra is what connects the bladder to the outside. So one of the things that happens in UTI is when we can't fully empty that bladder, that urine stays inside, and then all those organisms begin to collect. What do you think is the most common way or reason that a UTI happens with the bladder management program? Anybody?
Catheterization.
Catheterization. And it's because when you go back to this slide, as we introduce a catheter into the urethra, there's many things that could be on that catheter that can create that bacteria and give it room to flourish, which we don't want. All right, so when the bladder is overfull and stretched, usually it's typically for men 500 milliliters. Women, it could be greater than 400, but everyone's different. Every single patient's different. And I can also say every single treatment plan is really unique and different. What we are trying to avoid in the inpatient setting and even teaching everyone to watch for once you're at home is autonomic dysreflexia. So that's a medical emergency. And we want to make sure that that doesn't occur. So during the time on the unit, we usually give patients information in a spinal cord injury book. We talk about autonomic dysreflexia. And even though there's some common levels of injury that you see it, we actually watch at all levels of the injury to make sure that that doesn't occur and respond to those medical emergencies. Our provider team is amazing. So they respond to those emergencies as soon as they need to if it occurs. This can cause backflow into the kidneys when there's distension and the urine is not empty. So one of the first things we do when we think that there's autonomic dysreflexia is actually empty the bowel and bladder. And we look for whatever the sign is or whatever the cause is for whatever is going on with the patient at that time. So some of the risk associated with bladder management and spinal cord injury then, of course, we've talked about is UTIs, and that is from, like you said, the frequent catheter use. It can be one of the causes. There's many others though. Bladder stones, which can develop due to chronic catheter use or incomplete bladder emptying. And then the autonomic dysreflexia we spoke about. So 3 common reasons people usually develop the UTIs and spinal cord injury. Well, number 1, most people lose the normal urinary function after the spinal cord injury occurs, and they need bladder management options to empty the urine from their bladder and help keep the bladder and kidneys healthy. Most bladder management options make it easier for that bacteria to enter. And that's why this year with our performance improvement project, we focused on looking at evidence-based research for our unit specific and then beyond, because we have many partners to reduce this as a risk factor. Most people also lose normal function of their bowel after spinal cord injury occurs. And so, as you know, I'm sure contact with the stool during bowel management can occur. And stool has bacteria that once in the bladder can cause infection. So we want to make sure as the patients and as the beginning of the journey starts that we're teaching everyone this so that you're recognizing when you're cleaning properly prior to utilizing the catheter. And once in the bladder, the bacteria is very hard to get rid of. So people with normal bladder function can usually get rid of that bacteria by just fully emptying their bladder, right? But in those with spinal cord injury that can't empty that bladder, we just have to have a really good bladder management program for them. So that's our focus on our 6 North unit. These are some of the symptoms to watch for with UTIs, and I'm sure you've been shown this in the past as well. Some of the symptoms to watch for would be cloudy urine, dark colored urine, grit or blood in the urine, a foul or strong odor, fevers, chills, just feeling sick, nausea, vomiting, increased spasms and burning or flank pain if you have sensation. And there's multiple treatments. We always make sure that at discharge that you look to your healthcare professionals and partners to get answers when you're starting to have these symptoms. But what I can say about that is to make sure that as soon as you begin to feel those symptoms, you want to make sure you reach out to your providers. So those are just some of the options. If you're put on an antibiotic, you want to make sure that you complete that antibiotic as prescribed. And we look at during the inpatient stay, making sure that it's the right antibiotic at the right time as well. We want to prevent bounce back infections on our patients. So some common bladder management options that we use, which you've heard of, I'm sure, the intermittent catheterization, which we talked about, indwelling catheters, which we only utilize if there is a chronic issue for the most part on our unit. Now that may end up being an option later on based on the providers. But what I want to say about our 6 North unit here at MetroHealth for the indwelling catheter in 2024, 2023, and we're set for hopefully 2024. We actually won a quality award for having 0 catheter-associated urinary tract infections related to indwelling catheters. That is always our goal. We also see some patients who choose the suprapubic catheter, and then we utilize many external collection devices on our patients as well. So when we develop the program for each patient as they're going through the journey, it's different for everyone. But this is an example of what we teach, and we want each patient to individualize it based on your needs, which our providers and our entire interdisciplinary team assist with. Right, here's just an example. So the catheter at scheduled times is very important. Usually we do it every 4 to 6 hours on our unit, sometimes more, sometimes a little less. But an example could be a scheduled time of 6, 12, 5, 10. And this would be something we would be teaching the patient for homegoing and checking the bladder in the middle of the night and making sure they cath if necessary. We also, when we see large volumes, because we don't want the bladder overstretched and leakage to occur where you have unnecessary accidents, teach our patients to make sure you're limiting your fluid intake, and specifically at night, which I hope all of you know that. And so 2,000 milliliters seems to be the target that works the best for most patients. So about 8-ounce glasses of fluid, and then avoid those fluids in the late evening. So what exactly are we doing with this program at MetroHealth? Some of the other things we are teaching our staff to do is early identification of the caregiver or support person for the patients as you begin that journey. Is very important for everyone to begin thinking when you're in that beginning stage of who is going to be that care partner that's going to assist you. And I have some recent patients here that know that about me, right? You raise your hand, okay. So we talk about these things, and we train our patients and the identified care partners. So what we've done in the past years, we try to do it earlier in the stay, because the earlier the better, so you can get that practice and simulate what you're going to do in the home environment before you get home. We also look at allowing the practice during the stay to simulate that home routine. So we invite the care partners, the family, the friends, whoever is that person our patient says they want to come in and stay with them and do the care so they can see how this is going to work in the home setting. Then we look at utilizing sterile techniques. So of course at home we teach clean technique, right? But at the hospital, I prefer double, triple sterility, because we want to make sure there's too many organisms in the healthcare environment. So our staff are tasked to make sure that when they're doing intermittent catheterization or procedures with our patients, they remain sterile. And then utilizing catheters that help to decrease the UTIs, which we're going to talk about next. So from rehab to home, we ask that every patient practice everything while they're in rehab. And, you know, my focus right now is talking about bladder management, but we do it for every thing that we do. We work with our PT, our OT, our speech partners, our providers, and we want to find any problems before you go home so that we can talk about those things and help you work through the barriers so that you can be successful at home. We've had many success stories, and all of you in here have become experts at what you do, I'm sure, and you are all success stories. We also teach to practice good hand washing. Good infection control is so important in the home environment to keep everything clean. And then be able to talk a stranger through your care step by step in an emergency, so you can be prepared if there's any issues while you're out and about on your own. And congratulate yourself, because this is a hard journey. And what I have seen is that our patients, I feel like you guys become almost like the PhDs of your life. You are pros at what you do. And it's so much information you have to take in to get it done. So I congratulate you. We applaud your efforts. We love to see you come back. And we have a great support through our support group with Megan. And every Wednesday from, what time is it? 4 to 5. Thank you. Yes. Every week we have that ability to come together and you hear real life experiences related to spinal cord injury. So after discharge, we always want you to seek professional help if you have any concerns or issues that come up with your healthcare professionals. And we also tell our patients as they leave the unit, you can always call us because we're there 24/7. There's always someone who can take the question, even though they may not right away have the answer, and try to help you and navigate that situation to get you the help that you do need. So, questions about bladder management. We're going to talk about that after we have some of our experts talk about products that have been helping us throughout the MetroHealth system decrease the UTI rate. And one in particular is Hollister, who has been just added on in this past year with our journey to reduce more UTIs. And then we also had out in the lobby, if you got to talk to Convatec as well as Coloplast, which we also use their products. Because again, it's not a one size fits all. Insurance, as you know, can create many barriers to what can and cannot be accepted at home. So it can change from the hospital environment to that outpatient environment. So I'd like to introduce Rachel Boeche, who's going to talk about her product and how it's helped to reduce UTIs.
Hi, everyone. I'm Rachel. I'm with Hollister. I'm an occupational therapist by trade. I worked for about 8 years on an inpatient rehab spinal cord unit down in Miami. So before I came to Hollister, this was kind of like my life, right? Trying to determine what the best catheter system was for our patients, and what they chose ultimately was what we wanted them to go home with, and helping them decide on how we could integrate that into their life. So lots of experience with this beforehand, but now I just, Shenell invited me here to talk about our product, which has been utilized in this new initiative, and kind of the features that have really benefited the patients on the unit in MetroHealth. So just our company in itself we're a global healthcare manufacturer. And we've been serving customers with ostomy and continence care needs for over 100 years. And our mission is to make life more rewarding and dignified for those who use our products. So the Vapro catheter that I'm going to show you guys now, and if you want to stop by the booth, I know some of you have done that to see what this is all about. There was a study that was published earlier this year in the Journal of Wound Ostomy and Continence Nursing. It was an independent study that talked about the benefits of a tipped and sleeved catheter. So I just want to go over what that means and why that would be important for infection prevention. And this is the video that's not going to work, so we'll skip that. Okay, so with a tipped and sleeved catheter, and this can be any tipped and sleeved catheter. It doesn't have to be Hollister. And that's the beauty of this study, was it was an independent study, right? So they looked at several different types of catheters on the market. Just so happens that Hollister has a tipped and sleeved catheter. So what that means is, I'm sure a lot of you are familiar with a catheter that has a sleeve around the catheter itself, right? So you're not touching it. It's ready to use, it's lubricated already, but you're not actually putting your hands on it. The benefit to the tip really is when you look at the distal urethra, especially for males. For males, there's about 15 millimeters that are inside that distal urethra you cannot clean it, no matter how much you try with sterile technique, with clean technique, there's still going to be some bacteria there. And basically what that study showed, and I think we have a slide next, Shenell, if you want to keep going. Nope.
One more?
Maybe. One more.
One more.
No. Okay.
Okay.
Anyways, sorry.
That's
So basically what the study showed is as that protective tip is passing through the distal urethra, it's bypassing all of those bacteria. So if you can imagine, this is 15 millimeters of the distal urethra, the tip goes in and it bypasses all of those germs. As the catheter gets inserted up into the bladder, there's virtually no microbes that are heading up into the bladder. If you take a regular non-tipped catheter, no matter how much you clean, right, you're using gloves, you may have a sleeve around the catheter, you're not touching the catheter, but as soon as you touch it to your urethra, your meatus, it's still touching your skin and parts of areas that haven't been cleaned thoroughly. So that's really the MetroHealth initiative to help prevent UTIs, especially on the unit. Utilizing a tipped and sleeved or like a completely enclosed system has been, I think, really helpful. And like Shenell mentioned, not just Hollister catheters, but any catheters that have that tip and sleeve can really help prevent UTIs.
Very good. All right. And so with that being said, Catie, I'd like her to come up as well. This way or that way, either way. Okay, yeah, there's stairs. And Catie is our partner who is here with us from Convatec. And so I would like for her to also show you, because this is another option that we utilize at MetroHealth as well.
All right. Hi, I'm Catie. I'm with Convatec. I did not know that I was presenting. I don't have a fancy slideshow or anything.
That's okay.
And just did some notes on my phone. So my experience, I was an MA for 6 years. Prior to this, I spent 4 years in Eurobank. And and while I was there, I did urodynamics also. So I did the fun little bladder test I'm sure that everybody had to do. And then after that, I decided to join the military and served that country. And then I worked for Edge Park. And so I was there for 2 years. So I was on the supplier side of things. I know some of you guys are probably familiar with Edge Park. And then I got a job here at Convatec. So I'm super happy to be here. I absolutely love my job. And I've been here for about 3.5 years. So I am going to talk about kind of the same thing that Rachel did, everything that she said, product is amazing too. And that she was talking about with the transfer of bacteria within the urethra. So we have a closed system one, just a traditional closed system, but what I want to talk about is our Dextra. So Dextra is going to be, we geared this towards patients with dexterity issues. But you don't have to have dexterity issues to use this product. So the patient, these are reinforced loopholes, so the patient is going to pull on this and open it up. And then pull this out. This was my bag for a little bit. So there is an insertion guide on here for the patient to use if you need some little instruction, because sometimes it can be a little overwhelming when you get home and you kind of forget how to do everything. So there is a loophole for the fingers or the hand that the patient can hold onto. The tip of it is going to come off. And then there is a foam arrow. So the patient, to be hands-free, can just kind of go back and forth like that. Or again, for dexterity issues, it's foam, so the patient can use their palm and move the catheter as well. So the reason why this one is different than that is that this is the only non-retractable catheter on the market. So I will grab this with my hand and try and pull that or push that catheter back in that bag. It will not go back in. Where the other catheters, even this one, will go as you're inserting it, will go back in. And then when they're done capping, there's a little loophole right here for them to pull, and then they hold on to here, and then they empty into the toilet. Also, what makes this one different, and the closed system will go along with this as well, is that the tip of it is called the Protex tip. So all the other catheters, some of the other catheters, when they're made into a, the opening goes through a mold. So what we did was ours is actually made completely closed. And then we do a Protex tip cut. So there's an X cut for that catheter to be able to go through. So what we did, there was actually a study out of Oxford University as well. And I have a flyer and the study at my booth if I didn't talk to you already about it. So what we found was that at 5 to 7 millimeters, what Rachel was talking about with the bacteria going through the urethra and everything, that here, both catheters at 5 to 7 millimeters, it completely stopped moving the bacteria through the urethra, where the other ones did not as well. So I think that's all. I don't know.
Very good. Thank you. Thank you.
Took the notes really quick.
Yeah, so I appreciate it. And
No.
so
I don't have a fancy slideshow.
that's okay. So for you and Rachel, we want to ask some questions. So one of the things that, you know, we always have concerns about and making sure that the discharge plan is going to be successful is coordination of care as related to if something is going to be covered. So can you explain, either of you, the process for getting the closed system catheter reimbursed through insurance?
Just in general, I think, like how you would guide somebody to. So, in terms of the Medicare requirements and when we say Medicare requirements, a lot of commercial insurances will follow what Medicare says. So Medicare kind of sets the gold standard. This doesn't mean that your insurance will work this way, but this is kind of what the industry goes by. So the Medicare guidelines basically say that in order to qualify for a closed system catheter with a bag attached, you have to have had 2 distinct UTIs within a 12-month period that have been documented. So somebody wrote that you had a UTI of, let's just say, E. coli bacteria, And then 6 months later, you came back to the doctor, you had a different UTI, let's say Klebsiella. Those are two different bacteria, two different UTIs, right? So documenting that would automatically qualify you for a closed system. This is America, we make people get sick before they get better. So unfortunately, that's the current way of doing things, unless your doctor can document that you qualify as an immunosuppressed individual, or if you can qualify as a pregnant woman with a spinal cord injury. So that's, I don't think anybody in this room. And there's a lot of little loopholes that, you know, Medicare tries to make open, but then it's not open, right? So what you can do to help mitigate those things, and something that Medicare came back recently and said was, okay, if you have a T3 spinal cord injury or higher, you're more prone to autonomic dysreflexia, and that could be a potential immunosuppressing disorder, and we are going to qualify you automatically. So as of now, if you have a T3 or higher, it doesn't matter your ASIA score. You could be an ASIA D walking around complete function, but if you're a cervical level injury, you would qualify. Okay, so what manufacturers are trying to do, and Hollister, Convatec, Coloplast, we're all in this together, is we're trying to get Medicare to understand that our individuals with spinal cord injury are immunosuppressed because of a spinal cord injury. There's a lot of new research out there that talks about how spinal cord innervates your lymph nodes, it innervates your spleen, it innervates your bone marrow. Those are all organs that help with your immune system. So why are we only limiting it to people with T3 and above? It should be anybody with a spinal cord injury could qualify for this closed system. Why are we limiting access? Why are we making people get sick before we can give them the quality product? So that's something that we're working towards. I'm very passionate about it, as you can tell. I think access is super important for end users. So if you have questions about how you can qualify at this point, you can always reach out to your service rep, your manufacturing rep, your caseworker. If you're on Medicaid, you have probably a Medicaid caseworker. They should know about those things. So those are just some avenues that you could take.
That was great answer. I'm not in that detail. I will add, when you're talking about the two documented UTIs, that your doctor also in the note, they have to put the type of symptoms that you're having in the note as well for it to be able to go through. So whether it's burning or fever or any of those symptoms like cloudiness, all that stuff. And then also when they do, so they actually have to send it out for a culture. So if you get a culture result and it says no growth, that will not qualify. There has to be a growth of 100,000 colony count or higher. So I'll just add that.
Very good, thank you. So just to kind of segue from what you've said though, with the immunosuppression, what is the rationale in the studies that they're finding with the evidence of why it could be potentially related to the recurrent UTIs?
So, and Dr. Wilson, I don't know if you have anything to add to these things, but this is kind of emerging research that has really been talked about at conferences over the last 2 to 3 years. Is, like I said, the spinal cord innervates at all levels, right? Like we're talking low thoracic, even at a low thoracic spinal cord level, some parts of your bone marrow, your spleen, those are immune organs. Those are organs that help you fight infections and decrease the chances of you getting infections. So the recurrent UTIs, we're talking, once you have a UTI, how is your ability to fight that UTI? And studies are showing that individuals, even at a low thoracic level, have a harder time getting rid of a UTI than somebody who is able-bodied. So the thought process is that there is an immune component to that. And that's why we're trying to get Medicare and the government to understand that people with spinal cord injury, no, you don't have to take medicine because you're immunosuppressed, but your body has a harder time fighting infection. So why should we make you get sick before you qualify for a product that you should have if you want it, right?
Very glad. Thank you. Dr. Wilson, did you have anything to add?
Yeah, I mean, it's interesting new research over the last 5 or 10 years, the Spinal Ohio State putting a lot of effort into it. And unfortunately with plant use, there's a lot of things combining against you, that between colonization of bacteria in your bladder, the autonomic fight and flight nervous system related to the autonomic dyslexia that, as we mentioned, your body's often just working on, getting through the day and calming down the immediate issue. And so some of these things, were healthy homeostasis for you to make the immune cells and all these kinds of things that aren't the priority. So it's something that we've talked about before. I'm curious to see what Medicare says when you go back and tell them. Because if that's the case, I'm happy to, rubber stamp all the cases and everybody's best.
Actually, we have, Hollister, on behalf of all the manufacturers, retained, Powers Law Firm, which is a huge disability advocate law firm. I'm sure United Spinal, I think, is very aware of them. I think they helped, in some cases, getting some, policies pushed through. So they have their big final meeting with Medicare within the next month or two. And we've just put like literature upon like study, medical expert, Medicare recipients who are getting denied. So hopefully, I mean, how could they say no, right? But we'll keep fighting. That's all I can say.
Keep fighting, right? Thank you so much. And so we have just a couple of minutes, and before we go, I'm looking at that clock back there. We're closing time. I just want to make sure if you have an opportunity that you stop by and speak with them again now that you've heard more about the science behind the technologies. And are there any last questions? I could probably take at least 2. If you have more, like I said, we're on 6 North 24/7, right? So we appreciate you. And one of the other things I just like to end with saying is that back to the nursing staff and the expertise in growing that. This year, we actually have 15 nurses in our Rehab Institute that will be going through the Certified Rehabilitation RN exam. So we are continuing to grow and expand that rehab knowledge. I myself have been a CRRN since 2008. And I was able to actually write for the exam last year, which was a great experience for me. They wouldn't let me tell my staff what those questions were, so they don't tell you if they use your question. But we are very super excited to continue to provide quality, exceptional care to you. And we really thank you for choosing us.
You did a fine job.
Thank you.
And thank you so much. We will have just over 15 minutes of a break. It's 1:12 now. We'll start again at 1:30, and we'll have Josie Scott joining us virtually from LA to be our keynote speaker at 1:30. So bathroom break. I don't know if cookies are out there yet. They might be.